Hi class, welcome to Unit 5, the second PowerPoint discussing HIV and AIDS. So AIDS is the second most common immune deficiency disease in the world. It was first identified in 1981, and it is a serious worldwide epidemic. Um, there are some effects of HIV. Um, Let's see. So everyone in the AIDS, everyone with AIDS has HIV. However, not everyone with HIV has AIDS. So the number of CD4 plus the number of T cell a patient has, whether they have had any opportunistic infections, indicates the difference. So the immune system can attack and destroy that virus early on, but eventually the number of HIV particles overwhelm the system with time. So with an HIV infection, CD4 cells begin to produce new HIV virus particles. Antibodies produced are incomplete and do not function well. Our macrophages stop functioning correctly, and then opportunistic infections and cancers are the leading cause of death with HIV infection. So let's talk about the transmission. So HIV infected individuals can transmit HIV to others within just a few days after becoming infected. HIV is a fragile virus and it's transmitted only through contact with body fluids, blood, semen, vaginal secretions, and breast milk. And the single most effective practice for healthcare workers providing direct care to an HIV patient is via consistent use of standard precautions. Standard precautions will protect you. So this slide talks to you a little bit about sex with an infected partner. That is the CDC's recommendations of how to have safe sex. So this is what we would want to advise our patients on. Prior to the identification of HIV, a very small percentage of people got HIV through exposure to blood products, but now we test our blood banks for that. But if you are exposed to another individual with HIV and it gets into you, you can get HIV that way. So that is a common way for or risk for healthcare workers. And if you remember back in pharm, if you get a needle stick from a patient that has HIV, we recommend 4 weeks of antiretroviral therapy to prevent conversion. And then pregnancy, delivery, and breastfeeding is another big segment of education. So with treatment, this can be a very, very small number, but it's a matter of nurses providing this education to patients so they can make good decisions. There are some laboratory values that we're going to monitor. We're going to monitor the VL, which is the viral load, and that is just the amount of virus that is present in the blood or other body fluids. The higher blood levels of HIV, the greater risk for transmission. Our goal with ART, if you remember from pharm, is a viral load less than 20. The other laboratory value is the CD4 and the T cell count. So the CD4 T cell count, immune systems problems begin once you get to that 500 level or below. Normal range is 8 to 12. So once you get to that 500 or below, it allows for opportunistic diseases to take hold. And then severe problems begin to develop below a 200 CD4 T cell count. And remember that opportunistic diseases are the main cause of disease, disability, and death in HIV infected patients. Okay, this slide just shows you the inverse relationship between HIV viral load and the CD4 cell count. And the viral load in the infection. During the time of low viral load, which can last 10 to 12 years or longer, clinical symptoms can be limited. Even without the symptoms, though, HIV replication occurs at a rapid and constant rate in the blood and lymph tissues. A major consequence of rapid replication is that errors can occur in the copying process, causing mutations that contribute to treatment difficulties. And remember that acute retroviral syndrome, that flu-like symptoms that happen with the initial infection, and then we go up for a prolonged period of no symptoms. So this displays the typical course of untreated HIV infection. However, it's important to remember that the disease progression is highly individualized and that treatment can significantly alter this pattern. The information depicted in this figure represents data from large groups of people and can't be used and should not be used to predict an individual's prognosis. So, with that acute infection, remember the flu-like symptoms lasts about 1 to 2 weeks, and it occurs about 2 to 4 weeks after they get the infection. Some people can develop neurological complications like meningitis, peripheral neuropathy, facial palsy, or Guillain-Barré syndrome. During this time, a high viral load is noted, and the CD4 T-cell count falls temporarily, but then it returns to baseline. Many people, including healthcare providers, mistake acute HIV symptoms for a bad case of the flu. So then that brings us to the early chronic infection phase. This median interval between untreated HIV infection and a diagnosis of AIDS is about 11 years. During this time, the CD4 T-cell counts remain above 500, normal or slightly decreased, and the viral load in the blood will be low. This phase has been referred to as the asymptomatic disease phase. During this time, infected people continue their usual activities, which may also include high-risk sexual and drug-using behaviors. This is a public health problem. That transitions into the intermediate chronic. So any symptoms that were seen in earlier phases tend to become worse. It can cause persistent fever, frequent drenching night sweats, chronic diarrhea, recurrent headaches, and fatigue severe enough to interrupt normal routines. Other problems that can happen include localized infections, lymphadenopathy, and nervous system manifestations. So it's transitioning to a more active state, and those CD4 T-cell counts are dropping lower. So some symptoms: thrush, which is oral candidiasis infection, and we usually would treat that with nystatin, which it can be taken as a liquid, swished in the mouth for a few minutes, and then you can either spit it out or swallow it. You also can see oral hairy leukoplakia, shingles, persistent yeast infections in the vaginal canal, herpes, bacterial infections, or Kaposi Sarcoma, which you can read about these in your textbook. And I've got some pictures. So this is a picture of oral thrush. This is Kaposi Sarcoma. So these are malignant vascular lesions. Sometimes we abbreviate this KS, and these lesions can appear anywhere on the skin surface or even on the internal organs. The lesions usually vary in size from pinpoint to very large and appear in a variety of shades. We have to be very careful in how we dispose of any soiled dressings from these lesions. That's a high priority consideration. Okay, and then that brings us along to the late chronic or AIDS phase. So remember that a diagnosis of AIDS cannot be made until the HIV infected patient meets the criteria established by the CDC. But it does have these things in common. So these are discussions of the common opportunistic diseases. Several opportunistic diseases can occur at the same time, which further compounds the difficulties of diagnosis and treatment of just what the heck is going on. Advances in HIV treatment have led to decreases in the number of opportunistic diseases because successful treatment maintains a better functioning immune system, and opportunistic diseases take advantage of a poorly functioning disease system. So the pneumocystis, the cryptococcal meningitis, cyclomegavirus, mycobacterium, Kaposi Sarcoma, influenza, TB, all of these are linked to opportunistic infection diseases in the HIV patients. There are some other clinical manifestations. You can have some AIDS, type dementia. You can have AIDS wasting syndrome, and even some skin changes, or including petechiae or bleeding gums due to low platelet counts. Diagnostics. How do we figure out what's going on? So the most useful screening tool to detect HIV is they detect HIV specific antibodies. A rapid HIV antibody test can provide results in 20 minutes, and those are recommended by the CDC. Rapid testing is highly reliable and provides immediate feedback to patients who can then be counseled on treatment and prevention. This is an important advantage because many people don't return to get their test results when we use other testing methods. For example, the Western blot, that sort of thing. And that's why we do the rapid HIV and then we confirm it. We repeat it a second time to make sure it's not a false positive. And if you get a patient and they come in for an HIV test and they come back negative, the next thing that we want to do is do a quality assessment of what are their risk factors for contracting HIV, so then we can provide specific patient education on how to mitigate those. So if they're drug users, can we put them in touch with needle exchange programs? Do they even know that they shouldn't be sharing their needles with another person? So things like that come into play. So the other diagnostics we're going to do, we're going to monitor their progression by close monitoring of that CD4 T-cell count and viral loads. Generally speaking, a CD4 T-cell count of 800 to 1200 are considered normal. In HIV, viral loads are reported as real numbers, like 1,260 copies, or as undetectable. Undetectable indicates that the viral load is lower than the test is able to report. Undetectable does not mean that the virus has been eliminated from the body or that the patient no longer has HIV to transmit. We can also do resistant tests. There's two different types of resistant tests that can determine if a patient's HIV is resistant to drugs used in ART, Antiretroviral Therapy. And you don't need to know this, but one is the genotype assay and the other is the phenotype assay. And abnormal blood count tests, so we would look at our CBCs and then our liver function tests, the ALT, AST. So HIV is a collaborative disease. We need to work on monitoring the disease, implementing a treatment plan, preventing, detecting, and treating opportunistic infections, manage any symptoms or medication side effects. We want to prevent or decrease any complications, and then we want to stop the transmission. Drug therapy. I'm not going to go super in depth because ART therapy is constantly evolving. But our main goals, because HIV can't be cured, but ART can decrease viral replication and delay the progression of the disease in most patients. When it's taken consistently and correctly, ART can reduce viral loads by 90 to 99%, which makes adherence to the treatment regimen extremely important. What we do is we decrease the viral load, raise the CD4 T-cell count, delay HIV-related symptoms and opportunistic infections. And the major advantage of using ART is that we use multiple drugs from different drug groups in combination because it can attack that viral replication process in several different ways, making it more difficult for the virus to recover and decreasing the likelihood of drug resistance. So the current guidelines for starting ART are based on the degree of immunosuppression as measured by the CD4 T-cell count. Some issues to consider when selecting an initial drug regimen include the ability of the patient's HIV to resist specific drugs, potential medication side effects, existing comorbidities, and dosing schedules. This is a critical decision because the first treatment regimen is generally the patient's best chance for success. And so adherence is critically important. And what it prevents is the progression of the disease. It prevents opportunistic infections, and it decreases viral drug resistance. So ways to improve it is to understand each patient is unique and we need to tailor our education and recommendations to the individual patient. We can also encourage use of electronic reminders or timers. So setting your cell phone. So what time do you usually eat breakfast in the morning? Okay, we're going to set an alarm that time so you can remember to take your medicine. And then again at lunch and again at dinner. And then if a patient on ART has a sudden decline, and then we check the lab values and there's a large increase in their viral load while they're on ART, the first thing we are going to assess is their adherence to the drug routine. This slide just shows you on the beginning treatment recommendations. This is our at-risk patients assessments. Any blood transfusion clotting factors before 1985? Do they share needles? Are they sexually active? Have they had a previously sexually transmitted disease? And remember, if we assess them for these things, and then if they want a test, we're going to do the test. But after the test, even if it's negative, we have to continue our assessment for risk and ways to prevent them from getting the disease. So our main goals when we work with these patients is to keep that viral load low, maintain immune system function, provide and improve their quality of life, prevent opportunistic disease and new infections, reduce their disability, so make their lives be productive and worth living. Health promotion. How do we prevent HIV. So we're going to decrease risk. So good thing is to not to use drugs. If you do use drugs, don't share the equipment. So injecting equipment can include needles, syringes, cookers, which can be spoons or bottle caps used to mix the drug, cotton, rinse water. It could be equipment used to snort, like straws, or to smoke, pipes. All of these can be contaminated with blood. None of this equipment should be shared. Some communities have needle and syringe exchange programs that provide sterile equipment to users in exchange for used equipment. If they can't exchange, they should clean their equipment. Cleaning equipment before use is a risk reducing activity. It reduces the risk of sharing the equipment, but it takes time and it could be difficult for a person on drugs or suffering from drug withdrawal. All right, nearing the end. So, acute intervention. The nursing assessment of HIV disease should focus on the early detection of symptoms, opportunistic diseases, and psychosocial problems. As time passes, patients and their loved ones must confront common issues associated with any life threatening illness. They can include complex treatment decisions, feelings of loss, anger, powerlessness, depression, and grief. They can feel social isolation imposed either by themselves or others. We can have altered concepts of the physical, social, emotional, and creative self. They could have thoughts of suicide and dealing with the possibility of death. And then lastly, this is the criteria for diagnosis of AIDS. So when does HIV shift over to that AIDS diagnosis? Okay, thank you for listening, and please let me know if you have any questions.